guidance of fluoroscopy and other imaging modalities. So welcome to you, ma'am. Hope this will be a great learning experience and an opportunity for all of them to interact with somebody with as diverse a background as you. With that, over to you, ma'am.
Thank you so much, Dr. Deepak. So am I audible now?
Yes, very clear and audible.
Yeah. So thank you so much for your kind words, and I'm really thankful to TIPSECHO for giving me opportunity to talk on such a beautiful topic, which is I think, the backbone of palliative care, that is introduction to pain. So shall I share my screen now?
Yes, please, ma'am.
Okay. Visible to everyone?
Yes, ma'am. If you could put it on slideshow as well.
Yeah. So yeah, a very warm good evening to all of you. And a very important topic is introduction to pain. Now,
I'm just sorry for the interruption. Ma'am, can you put the PPT on slideshow, ma'am? We are able to see the page before that.
Like this, you mean to say?
Ma'am, can you press F5, ma'am, on the keyboard?
Yes.
Oh, ma'am, I think, is this a, you have opened in PPT, right, ma'am?
Yeah.
My...
Yeah, this is the PPT format only.
Okay, can you come to view?
Okay. Little waste of time. So a very beautiful topic is introduction to this pain. So just I'll walk through the introduction, and will you just, Shri Priya, move to the previous slide? The first slide? Yeah. So as in the background, you can see that some picture is there. So this picture is just to sensitize you that in case if the same prick is given to same amount of stimulus is given to all of you, will you all experience the same amount of pain? So the answer to this question we will discuss in the end after the presentation. Next slide, please. So walking through the presentation is first is the what exactly is the pain, what is the definition, how International Association of the Study of Pain defines pain, what is the pain pathway, how can we classify pain, what is the pathophysiology involved in pain, and how do we assess pain, and what are the barriers in the pain management. Next slide, please. So this is a very busy slide with a lot of keynotes, and the International Association of Study of Pain in June 2020 defined pain as an unpleasant sensory and emotional experience associated with actual or potential tissue damage with the 6 keynotes. So actual tissue damage, everyone understands that there is a tissue damage. So proportional to that is the patient complains of pain. But sometimes there is also potential tissue damage, means that it looks like as if the damage is there, but it is not visible. So 6 keynotes they have given, which is very important, that pain is always a personal experience, as we all know, and that is influenced to varying degrees by the biological, psychological, as well as social factors. That is why now we have a concept of total pain, and what exactly is that total pain we will learn later on in few slides. Pain and nociception are a different phenomena. We cannot say that nociception is just only pain. So pain cannot be inferred solely from the activity in sensory neurons. It is just something beyond that sensory stimulus also. Through their life experiences, individuals learn the concept of pain and how to cope up with that pain. A person's report of an experience as pain should always be respected. Although pain usually serves as an adaptive role, it may have adverse effects on function, social, and psychological well-being as well. So there is a verbal description is not only it is not the only of the several behaviors to express pain. Means pain can even be expressed other than the verbal modality as well. Inability to communicate does not negate the possibility that a human or a non-human animal experiences pain. So there are so many other modalities, facial expressions, other this so many questionnaires are there, so many other things are also there, just to um, uh, express pain, but not only the verbal description. Next slide, please. So many people report pain in the absence of tissue damage or any likely pathophysiological cause, because in throughout our graduation and everywhere in the medical science we have learned that pain is usually directly proportional to the tissue damage. So now it is the time to unlearn the old things, because it is not always true. If they regard their experience as pain, it should be accepted as pain according to the IASP. Next slide. So now, why we say so that there is a pain can be there even without a tissue damage. The very important example is a phantom limb pain in that, because they have pain in their limb which is not there. So that means that the damaged tissue, in case if the patient is suffering from any osteosarcoma or any other in case of even after trauma, after gangrene or something, and they have their limb amputated, so still they can have pain in that limb which is not there. So if the pain is always associated with the actual or a potential tissue damage, that they should not feel pain on the limb which is not at all there, which is absent. So how these patients feel pain in the absent limb? So till 1960 they were sent to psychiatrists thinking that they must be mad because of the complaining of pain on the limb which is not there. They think that the person is depressed, or his psychology is disturbed because of the absence limb, and that is why he's feeling pain. But now it is a well established phenomena with clear pathophysiological explanation that it is something else. We'll just see now. Next slide, please. So it is the phantom limb pain and any other chronic pain. Here, the problem lies in the nerves and not in the damaged tissues. Maybe that amputated limb is cut, but they have not cut at the nerves, which is directly supplying through the spinal cord to the brain. And so that is why the pathology lies in the nerves and not in the damaged tissues. Next slide, please. So now what is the magnitude of the problem and why we are gathered and discussing this problem? Because 1 million people of cancer pain are there in India, and cancer pain is such a severe and excruciating and devastating combination of cancer pain along with the cancer along with pain, and severe pain make daily living impossible, and it affects not only the patients but also their family as well as the entire community. Next slide, please. So cancer pain remain undertreated throughout the world. In case if we see in India or even abroad, it is always undertreated. And the current status of cancer pain management in India is only 3% of the patients are receiving pain management because of so many other barriers we will discuss later on in the few slides. Next slide, please. Now coming to the how we can we feel pain. So many things we have learned in the past also, and what is the pathophysiology which is involved in pain. So what is the pain pathway? Next slide, please. So this is a simple graphical representation which says that the pain pathway is a little bit of complex structures. I will not go into much more detail, but there are certain steps, 4 steps, which are involved and are very important just to understand about the pain and about the how the pain is increased and how the pain is decreased over a period of time. So here you can see that it is the very important part is the transduction, transmission, perception, as well as modulation. So the first thing with this graphical representation only, I'll try to explain that transduction is the just whenever any trauma or something is there, or any stimulus is there, so that change of energy from the different stimuli, that is the chemical stimuli or mechanical stimuli, into a electrical energy which generates the action potential, is known as the transduction at the periphery level. And then this transduction is taken by the A delta and C fibers to the dorsal horn of the spinal cord. And from this the dorsal horn, the first order neurons ends up, and the second order neuron starts, and it moves to the contralateral sides till the thalamus. That is known as the transmission. And from this transmission is ultimately it goes to the sensory cortex, that is the post central cortex, that is the sensory cortex, where the perception takes place. But it is not necessary that the stimulus, that the action potential from the thalamus, it goes only to the sensory cortex. It can even spread sometimes to the limbic nuclei, to the limbic nuclei, and as well as to the reticular formation and to the periaqueductal gray matter also onto the opposite side. Now, what these structures do, in case of the next slide, please. Next slide. Okay, next slide. Okay, so what happened was that a functional MRI was taken previously in certain animals, and they have seen that in case if any continuous stimulus is given to a patient, that not only the post central gyrus is stimulated, but also the, as you can see here, that the periaqueductal gray is also stimulated, the reticular formation is also stimulated, and the limbic nuclei is also stimulated. As we have learned in the definition of the IASB, that pain is an unpleasant sensory and emotional experience. So it is written as emotional experience. So and emotional experience means from where the emotions are coming. The emotions are coming from the limbic nuclei, because the stimulus, it gets scattered from the sensory cortex to the limbic nuclei to the reticular formation. Now, what is the function of the reticular network? Reticular network always makes us awake, because in case if any stimulus is given to us, suppose I usually give this example that in case if any pinch is any pinching is done by your friend or someone close to you, so and you are sleeping soundly, suddenly you get awake and you feel pain. So you are feeling pain, and along with that you are getting awake also. So that is why a patient who is there in pain is usually complain of problem in sleeping, inadequate sleep, because pain never let you sleep. So that is why, because of these areas in the brain which are getting involved, that is the limbic nuclei and the reticular network. Please, next slide, the previous slide, please, the graphic representation. Yeah, yes, the previous one. Next, previous one. Yes. So what happened is that from the first order neuron, the neurons, they move up to the opposite side and they goes to the thalamus. That is the second order neuron. And from the second order neuron, it goes to the sensory cortex. That is the post-central gyrus, and the pre-central gyrus is the motor cortex. So this post-central gyrus, it gets scattered and it moves to the areas of limbic nuclei and the reticular formation. Now, these are the three important steps, that is the transduction, the change of the energy from the chemical and the mechanical stimuli to the this thing electrical transmission, electrical energy, that is the action potential, then the movement of the action potential from the dorsal horn to the thalamus, and then from the thalamus to the sensory cortex. Now what happens is, these, I think everyone know about these things, that transduction is there, transmission is there, and perception is there, but a very 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 important part is there, that is the modulation. Now what is exactly is this modulation is that some of the sometimes what happens is, this modulation is usually a natural response, a natural physiological response of our body, which suppresses the pain. Means this is a natural healing technique which is given by the god to us, which suppresses the suppresses the pain. Now, how it happens is, we'll see in the next slide. Next slide, please. Next slide. Next one. Next one. Okay. So this is just about the transduction, that pain is produced by the noxious stimuli, nociceptors, which are there as a free nerve endings of the primary efferent terminus, that is the A delta fibers and the C fibers. Now the action potentials are generated as the nociceptors transduction and carried to the higher cortical centers to the thalamus by transmission. Next slide. Transmission is the first order neuron from periphery to the dorsal horn. Second order neuron is contralateral spinothalamic tract to the thalamus. And third order neuron is thalamus to the somatosensory cortex, that is the postcentral gyrus, which is the perception. Next slide, please. Perception is at the postcentral gyrus. We have learned that is the sensory cortex. Next slide. Now coming to the modulation. Modulation is a neural process that reduces the activity in the pain transmission system and reduce the perception of pain in the healthy individuals. Next slide. Now these are the four categories, the four subtypes in which the modulation can occur. Now, so I told you in the simple language, modulation is the natural physiological process of suppression of pain. It is just to decrease the pain. This is a natural mechanism which is given to our body. So this is via the first mechanism is the descending inhibitory system. This is the strongest modulatory system which is given in our body, is the descending inhibitory system, that the fibers, that the action potential, it comes and it again it comes to the dorsal horn, and at the dorsal horn the two receptors are there, that is the noradrenaline and serotonin are there, and these gets activated. And after the activation of noradrenaline and serotonin, the endogenous opioids are secreted at the dorsal horn, which therefore suppresses the pain, and the subsequent from first to second order neuron, the suppression of the action potential is further generated. So this is what is the strongest descending inhibitory system in our body. The second one is the gate control theory, which is given by the Melchick and Paul. And he says that in case if the larger diameter fibers are stimulated, like the A beta fibers, which are the touch fibers. Suppose I'm having a pain in my abdomen, and in case if I keep on touching, because keep on touching my this tummy in the rotating fashion and stimulating the A beta fiber of the same dermatome, so that are the thicker and the densely thickened fibers. So though those fibers will come and close the gate and will not allow the smaller diameter fibers, that is the A delta fibers as well as the C fibers, to cross through that gate. So that is what is the gate control theory. So endogenous pain modulation system is those endogenous opioids which are automatically generated by the body at the dorsal horn, just to reduce the further action potentials in the second generation neurons. Then comes the segmental inhibition, that is the release of inhibitory neurotransmitters. Neurotransmitters are also secreted, that is the glycine and GABA, which results in further reducing the action potential of the pain fibers. Next slide, please. Now coming to the classification of pain, how do we classify pain? Pain is classified as into two broad categories, roughly, or nowadays we can say that into the three categories, that is in nociceptive, neuropathic, as well as the nociplastic also. So nociceptive pain is something which is a somatic and visceral, like a bony pain or a hepatic capsular pain in case of visceras. Neuropathic pain is the pain which is coming from the nerves, that is the either by a secondary neuroma formation, nerve infiltration, or spinal cord compression. Next slide, please. So now nociceptive pain is there and the neuropathic pain is there. Nociceptive pain is when there is a non-neural tissue damage, and neuropathic pain is that when there is a neural tissue damage. So, and in between these two, the category is there, that is the nociplastic pain, That in case if sometimes what happens is, as we are saying that there is a tissue damage, so that is why there is a pain. So when there is a tissue damage, there is a nociceptive pain, that is either a somatic or a visceral pain. But when there is a damage in the neural tissues, when the nerves who take the signals are themselves getting damaged, then that pain is known as the neuropathic pain. Now sometimes what happens is that the patient behaves as if this is a kind of a neuropathic pain, but there is no damage in the neural tissue is seen. So the category which comes in between these two, nociceptive and neuropathic, is known as a nociplastic pain, when the cause is not known but the patient behaves and the history is like that, as if it is a neuropathic pain. For example, is a case of a fibromyalgia also. Now into the nociceptive pain, what we say is nociceptive pain is usually a physiological pain, because pain is something which keeps you always alive. But when the nervous system itself is at fault, then it becomes chronic and it becomes pathological. Now, a simple relationship between pain and tissue damage is established, then it is a nociceptive pain. But when there is a dissociated relationship between pain and tissue damage, and this is a linger on pain, and the pain signals are taken up by the nerves, but these nerves themselves are at fault, then comes the neuropathic pain. Now, nociceptive pain is quite easier to diagnose because it is directly proportional. You can see the tissue damage, and there is that amount of pain is there, and you can very well diagnose and treat that patient. But neuropathic pain is a little bit challenging, and it is difficult to diagnose and treat because you cannot see exactly that where is the problem, and sometimes the entire somatosensory system is at fault. So it is a little bit challenging to treat, and it becomes chronic also. So inflammatory pain, visceral pain are the different varieties in the nociceptive pain, and they are easily can be treated with the use of anti-inflammatory drugs. Paracetamol, opioids, NSAIDs are effective to reduce pain. And in the neuropathic pain are the neuralgias, neuritis are the different varieties. And so, for example, is the trigeminal neuralgia. And here we cannot treat this pain with a normal NSAIDs or a non-steroidal anti-inflammatory drugs. Here we are using the adjuvant and the co-analgesics like anticonvulsants, antidepressants, etc. are used to reduce the neuropathic pain. Next slide. Now, according to the duration of pain, we can classify pain as acute and chronic. In case if the pain is less than 3 months old, then we say it as a acute pain. And usually in case if the pain is 3 to 6 months old, then we say that it is a chronic pain. And usually, roughly, it is not a dictum, but still they say that acute pain are usually nociceptive pain and the chronic pain are usually neuropathic pain. Next slide. Next slide. So pain is always an alarm. It is, it will keep you alive, and it is true for the acute pain, which is usually our friend, because we cannot survive in case if pain is not there. Chronic pain is a false alarm, and it is a disease itself, so it has to be treated, it has to be understood, it has to be assessed properly. Next slide, please. Next slide. Okay. So acute pain and chronic pain can be a chronic pain with tissue damage, or a chronic pain can be a chronic pain without tissue damage, as we have learned in the few slides. Next slide. Okay. Next slide, please. Now coming to the pathogenesis of the chronic pain, this is little bit complex, but I'll try to explain in a simple language. Next slide. Now, what is the pathophysiology behind this pain is that what what happens in case if the pain is becomes chronic even after 3 to 6 months old. And I asked you one question, that one prick is given to all of you, then will you feel the same amount of pain? So why it differs and how it differs depends upon the pathophysiology of pain. So what is a sensitization? A very important two topics are there in pain which needs to be learned is the modulation as well as the sensitization. Now, the ISP defines sensitization as an increased responsiveness of nociceptive neurons to their normal input or recruitment of a response of normally sub-threshold inputs. Sensitization is a key feature of neuropathic pain. So, in simple language, in case if we would like to understand, we can say that sensitization is something which is a abnormal response to a normal stimulus. Stimulus is normal, but the response is abnormal. So that is what is a sensitization. Modulation is something which is a decrease, and sensitization is something which is the amplification of pain. Next slide. So now sensitization is a phenomena of inappropriate or disproportionate response to a normal stimulus. Now it can be a peripheral sensitization or it can be a central sensitization. Suppose in case if something is happening in the periphery at the transduction level, then it is a peripheral sensitization. And once it reaches a before dorsal horn, it is a peripheral sensitization. And in case if it reaches from the dorsal horn to the above centrally, it is a central sensitization. Next slide. Okay, so peripheral sensitization is defined as the increased responsiveness and reduced threshold of nociceptive neurons in the periphery to the stimulation of their respective fields, receptive fields. So the abnormal phenomena of a normal stimulus in the peripheral nervous system is the peripheral sensitization. Next slide, please. Now, there are few factors which are responsible for the peripheral sensitization, that is the upregulation of active nociceptors. Now, what happens is that at the transduction level, at the peripheral neuron, so many times what happens is that the nociceptors are sleeping. Now, in case if the stimulus is coming again and again and there is a continuous stimulus of pain, then those sleeping nociceptors will become active and there is an upregulation of active nociceptors. Now, what happens is next to that is the sensitization of the efferent terminals. And what happens is the ectopic discharges along the nerve axon, which gives a deafferentiation and the accumulation of sodium channel. Now, what is this deafferentiation pain is that sometimes like so many neurons are there, axons are there, dendrites are there. What happens is when the action potential is generated along the entire pathway, the cell membrane is designed in a semi-permeable membrane, and the cell membrane is designed in such a way that it has so many sodium channels are there in it. And with these sodium channel, what happened that in case of continuous stimulus is coming, and sometimes just as an example, we can say that so many goods are coming in trucks on a highway, and sometimes in case if there is a block at the highway or some flyover, something that there is a break in that flyover, then what happens is that all the goods and the trucks will be accumulated at that part. So what happens, same thing occurs in the neurons, that same thing occurs here also, that in case if there is a damage at the neural tissue, then those sodium channels will get accumulated over there, and these will occur as will through the ectopic discharges and result in the deafferentiation pain. Now, what happens is next one of the factor is phenotypic switching, increasing expression of the excitatory neuropeptides. As a result of all these, the excitatory neurotransmitters are there, that is substance P, CGRP, nitric oxide, and sometimes glutamate also. These excitatory neuropeptides are increased in amount, resulting in more amplification of pain. And what happens is sometimes there is a somatic and sympathetic coupling is also there, that sympathetic nervous system also is one of the very broad and vast topic, that sympathetic nervous system also moves along with the peripheral and the central nervous system. And what happens is that sometimes there is a crosstalk in between the two, and there is an intermingling of the pathways between the sympathetic and the somatic, resulting in the more amplification of the action potential, resulting in the peripheral sensitization. So these are the few factors which are responsible for the peripheral sensitization, that is the activation of the sleeping nociceptors, then the sensitization of these efferent terminals, more discharges of the sodium channel because of the damage of that nervous tissue result in the ectopic discharges. There is more number of excitatory neurotransmitters, that is substance P, CGRP, glutamate, and glutamate, as well as nitric oxide, and there is a coupling in between somatic and sympathetic system. Next slide, please. Now, central sensitization is also the abnormal response to a normal stimuli, which is there in the central nervous system, that is beyond dorsal horn. So that is what is the central sensitization. Now, central sensitization also has certain factors. Next slide, please. Out of these factors, which play a very important role in central sensitization, the one is very important is the central reorganization. Now, what is the central reorganization? Next slide, please. There is something known as the neuroplasticity, which keeps on going on in our brain. Previously, there was a thought that the brain functions only till a few years of our life, like 5 to 10 years. But now there is a concept that neuroplasticity always keeps on changing the neurons, and whatever stimulus we are getting from the environment, from the peripheries, the neurons keeps on changing, and because of the results, so neuroplasticity is a broader umbrella, and secondary to that, under that neuroplasticity is the central reorganization which is taking place, and the result of neuroplasticity and central reorganization is something which is central sensitization. The effect of neuroplasticity is central reorganization. The previous slide, please. Okay, so this is what is a central reorganization, and the certain other factors are also there. That is the wind-up phenomena, upregulation of NMDA receptors. I'll explain later, and the ectopic signal discharges. Next slide, please. Next slide. So central reorganization is, again, it is having some three factors, that is the loss of descending inhibitory pathway. Now, what we have learned in modulation is that descending inhibitory pathway is one of the very strongest modulation mechanism in our body. So in case if that is lost, so that means that the central reorganization is the phenomena after the loss of those inhibitory pathways. Now, what happens is the A beta fibers develop connections in the rex lamina. Now, as we know that in our spinal cord, that rex lamina is there, and in that rex lamina, all the fibers are located, and in the periphery are the pain fibers, and in the center are the touch fibers, that is the A beta fibers. Now, what happens is that when the chronicity is there and when the sensitization is taking place, so what happens is that there is sprouting of these A beta fibers, the touch fibers, and when they sprout, then they get intermingled with the superficial res lamina pain fibers also. And in case if we are touching here, so suppose we are touching here, then the patient feels pain. So it is also one of the mechanism of allodynia, which is secondary to central reorganization, and we are touching and the patient is feeling pain, because touch is a normal stimulus and pain is an abnormal stimulus which is coming with this normal stimulus, second to the interconnections between these pain fibers because of the pathological and the neuropathic pain mechanism of central reorganization. Now, the area of the pain increases along the other nerve distribution because of interconnections. Now, as these interconnections they grow up, then the pain, suppose this is a pain-free area, so these pain-free areas reduces, and the widened up, there is an increase in the pain area, there is an increase in the area of the pain nerve distribution because of all these crosstalks and these interconnections. Next slide, please. Now, NMDA receptor is what happens is that there is a activation of these NMDA receptors. What happens is that normally they are inactivated, and but whenever that pain is there, so there is one more receptor is there known as the AMPA receptors, which dislodges the magnesium which is placed on these NMDA receptors, and as soon as the magnesium is dislodged, there is an activation of these receptors, and there is an influx of calcium inside, and there is an increased signal transmission, and there is a release of more excitatory neurotransmitters like nitric oxide, substance P, etc., and there is a more amplification of pain. Next slide, please. Next slide. So now, after learning from all these factors of central sensitization, which is the effect of central reorganization and neuroplasticity, what happens is that there is an increase in the intensity of pain, there is an increase in the area of pain, there is increase in the duration of pain, and there is a decrease tolerability to pain. Tolerance becomes lower and the intensity becomes higher. Development of psychological problems also, everything is interlinked, and the pain become non-responsive to the conventional analgesic. That is why it is much more difficult to treat neuropathic pain rather than a nociceptive pain. Next slide, please. Okay, so this we learned that visceral pain and somatic pain are the components of the nociceptive pain. Any stretch in the viscera capsule, like a liver capsule, it can be felt as a visceral pain. Bowel spasm, colicky, cardiac ischemia, visceral pain. Somatic pain is like a bone, cortical pain, trabecular pain, or a soft tissue pain. Next slide, please. Neuropathic pain is secondary to the nerve compression, nerve entrapments, or maybe there is a nerve injury which is at a peripheral level or a central level, or can also be sympathetically mediated. Next slide, please. Now, the nerve injuries pain, the examples are like the peripheral neuropathies are there, post-herpetic neuralgia are there, phantom limb pain as we talked previously. In the central pain, like the post-stroke pain, after the stroke, several months and years after the patient complains of pain, that is the thalamic pain, spinal cord compression pain, and sympathetically mediated pain. Next slide, please. Okay, so now the manifestations, what are the features of this neuropathic pain that after taking the history, it clicks to our mind that, yes, this is something which is abnormal. So the nature of pain becomes different. It becomes burning type, pricking type, aching type, shooting type, lancinating, electric shock type of a pain. These are the few features of this neuropathic pain. Sometimes it is there in the dermatomal distribution, like in case of disc prolapse, it follows the L5 dermatome, S1 dermatome, like that. And abnormal sensations like allodynia. Touch can be felt as only touch, but sometimes in these patients, touch can be feel as painful also. Next slide, please. So the features of the chronic neuropathic pain is allodynia, hyperalgesia. Even a small stimulus can can give an abnormal response. Character of pain, I told you, burning, shooting type, and associated symptoms are like numbness, tingling, pruritus. Patient will say that some as if the ants are crawling on the chest, and the feeling of pain and needles. So these are few characteristic of neuropathic pain, and there are wide number of questionnaire based on this, through which we can take account and make it as if it is a neuropathic pain or not. Next slide, please. Now, what is the etiology of pain in palliative care is that sometimes it is disease related, soft tissue infiltrations are there in cancer patients, nerve compressions are there, bone spread is there, metastatic spread, lymphedemas are there. Sometimes the patient is having metastasis to the brain, so they have the raised ICT, they have severe headache, which is refractory to usual conventional treatment, comorbidity related pain like the low back pain. Sometimes they have their already they have comorbidities like arthritis, trauma, treatment related to the surgery, related to the chemotherapy, related to the radiotherapy, and sometimes it is debilitated related, something like pressure sores in patients who are towards the end of life, constipation, and a bladder spasm also. Next slide, please. Now, what is the clinical relevance to all this? What we have learned is that the earlier the pain is treated, the less these perpetuating changes. The more early we treat the pain, the less chances of becoming sensitization, and less chances of the amplification of pain, and less chances of the pain becoming chronic and leading to all these problems. So all continuous pain warrant continuous analgesia. This is the crux of the story, and we should realize that each and every pain needs a treatment. Total relief is difficult if permanent changes have taken place. We cannot give false hope to the patient that the short treatment is 100%. Always give realistic hopes to the patient. Next slide, please. So now coming to this, that as we learned previously also, that it is not only, pain is not only after the physical trauma, it can be associated with so many other factors also. Suppose there is no stimulus, we are not putting any needle, we are not putting any IV line to the patient, still patient will say that I am having a lot of pain. And this concept was given by Sister Dame Cicely Saunders, that the total pain can be physical, can be psychological, spiritual, as well as social. So many other factors are also involved in this, along with the physical pain only. Next slide, please. Now, in this part, like in case if you want to go till the management in the subsequent training programs, the first thing in the assessment is to know the history of the patient. Unless and until we assess our patient, we evaluate our patient, we cannot manage the pain of these patients. So the history plays a very important part, and the 90% clues are coming from the history itself. The records are very important to check. Investigate only in case if it is required. Confirm the site where exactly is the pain. Identify the cause and establish trust. Next slide, please. And always while assessing, there should be eye to eye contact with the patient. Always give your clear introduction. Explain what you want to do. Keep realistic goals. Use terms which is appropriate to the patient, and don't keep over hope also. Next slide, please. Now, there are so many methods to assess pain. Can be a unidimensional pain scales also, and can be multidimensional also. So certain scales which we normally use is, the first is the numerical rating scale, and this is just a scale which is marked from 0 to 10, and you can just ask the patient that 0 means no pain and 10 means the worst pain, and in the middle you can mark 5 as the moderate pain. So how much the patient can rate his or her pain in the scale of 0 to 10. Visual analog pain scale, you are just showing the patient the scale and asking that where the pain stands in between 0 to 10. One is in India, the simple rupee scale, that how much paisa scale, how much paisa pain you have. That is much more easier for the patients to understand. Next slide, please. So pain is a fifth vital sign, and the quality care means that the pain is measured and treated. It is very important, because in case if the patient is coming and we are doing surgery, we are doing everything for that patient, and the patient is taking back pain to their home, so that always give a bad impression and bad memories to the patient. So pain is such an important vital sign which needs to be treated and needs to be addressed always. Next slide. So pain assessment is needs a multimodal team approach. Not only the patient, but also so many things we can gather from the family, also from the health providers, and everyone should be involved. That is the doctors, nurses, social workers, psychologists, chaplains, volunteers, physiotherapists, as well as the entire community. That how can we do the betterment of this patient, and how can we reduce the suffering of this person? Next slide. So when to assess? When the symptom is first identified as a problem at regular intervals in the cancer patients when they are coming for their follow-up. So all assessment needs to be done at the regular follow-ups. Always ask your patient whether you have pain or not. Whenever there is a significant change in the symptom, when the quality of the pain changes, then also it becomes important to address that pain. After medication, it has been administered, then also you should ask for patients, suppose in a post post-op patient, always ask that the medication is given after 1 hour, 2 hour, whether the pain is reduced or not. And after any modification in the treatment plan, we should always ask our patient whether it is increased or decreased, or what happened to the character of pain and the intensity of pain. Next slide, please. Now, assessment is simply based on PQRST plus 2. That is, we should always ask the best method is the self-reporting, that in case if the patient is able to say that I'm having 8 paisa pain or 9 paisa pain, then it is well and good. But we should always ask what are the provocating factors, what are the palliative factors, what factors are there which can increase and which can reduce the pain. What is the quality of pain? How it is, as I told you, burning type, needle prick type, throbbing type, pulsatile type. What is the quality of pain? Whether the pain is localized or it is radiating along the dermatome, something like a neuropathic pain. What is the severity of pain? How much is the intensity? How much severe? In case if it is very severe, then we cannot leave the patient as such, and with certain temporal characteristics also. So all these things needs to be asked whenever we are encountering the patient and they are coming in their follow-ups. Next slide, please. So what have you tried to relieve the pain, and has it worked? And how is the pain affecting the quality of your mood? What is the impact of that pain in his or her day-to-day life, mood, mobility, work, play, appetite, sleep, and daily activities? Because pain has a major impact on the daily activities. So we should always ask these points. Next slide, please. So type of assessment is self-report. I told you it is a gold standard. Observation, self-report, not fully trusted, means what people do. Sometimes they do something, they eat a lot of food. Sometimes they are depressed, they don't eat. So these things are there. Physiological, infants and critical care, other questionnaires are there, because I told you that verbal communication is not the only modality to assess pain. There are certain more other methods are also there to assess, to see the face, to see the expression, to see the parameters of the vitals of the patient. So many other things are also there to assess the pain. Next slide, please. These are also certain unidimensional pain scores, like the visual analog pain scale, numerical rating scale we routinely use, and categorical scale as mild, moderate, and severe. Next slide. Numerical rating scale is just like this. This is a pictorial presentation. Next slide. This is just a coin, how much paisa pain is there. Next slide. This is a facie scale, which is important. By the face, by the look of the picture, the child can recognize that how much is the pain. It is 4 or it is 6 or it is 8 or 10, like that. Next slide, please. Now, the patient can also mark the site on a pain map, that whether the pain is on the right side or on the left side. And this is a very good method of assessing pain, because on the subsequent visit, you can easily show the picture, and you can check that whether the site has changed, or the patient is marking to some other site, or there is a migratory type of pain or not. Next slide, please. Now, there are in the world of technology, there are electronic versions of self-report measures are also there, like the web-based diaries, and these can also be available, in which patient can mark that how much is the pain. Next slide. And touch pads are also there. They can touch the body parts on their app, and they can tell that where exactly it hurts, and drag the mark to show how much pain or you have right now. They can just drag on this scale, no pain, 2 more, that where exactly it is there in the middle 5, or it is towards the right side or the left side. Next slide, please. Now, as I told you that the pain assessment is never complete without a history. History is the baseline and the backbone of assessment of pain. So always ask in a cancer patient that when was your cancer diagnosed, what all the treatments you have taken so far, has your cancer related symptoms shown response to the cancer treatment, or is your pain incidence related in time to your cancer treatment, and did you notice any other unwanted effects during your cancer treatment? Next slide. So how bad is your pain on a scale of 0 to 10 to assess the severity? Does it interfere with your daily activities to assess his quality of life? Does it interfere with sleep, as it always has a limbic nuclei or reticular formation which keeps you awake? Does it occur at certain times of day, that is the diurnal variation? And has the frequency increased over time or worsened over time? And has it involved the other sides also, which just gives an alarm, and we can think of that something has, even there is a reoccurrence or a progression of the disease also. So next slide please. So do you have pain? Can you tell where exactly it is? Is it moving or it is radiating? And what is the duration? What is the character? All these questions are very important, and this gives a very good clue about the type and the character of pain. Next slide. Treatment of pain history is also very important, that what all the treatments the patient have undergone and they have responded or not responded, whether their pain is refractory or to the conventional treatment or not. Are you taking any medications? Do they believe your pain, means your family members, your caregivers? How much pain relief is obtained on a scale of 1 to 10, with 10 being the complete pain relief? And how long does the pain relief last? Next slide. So, just towards the end of the presentation, I would like to say that pain is multifaceted. It can never be static like this. Some days it will be like 4, some days it will be 2, but some days it can be 8 also. And accept pain as a normal consequence of cancer and minimize its impact on patients' overall health and survival, to reduce their suffering, and to improve their quality of life. Multimodal approach is necessary in case. And we also have to think that palliative care and pain business is not only the palliative care physician's business, it should be everyone's business, be it the caregivers, the family, the oncologist, the physiotherapist, the pain nurse, everyone's business. So individualized treatment according to the availability and the pain needs, what the person wants and what are his wishes, we have to individualize, because each and every patient is a different patient. And enhance always work. We cannot say that we can make your pain, we can make you pain free, we can make the pain free hospital, we can give you 100% relief. No false hope. Just try to reduce the pain as much as you can, and just try to increase their functional mobility and functional abilities as much as you can. Next slide please. So just a last slide about the barriers of pain management, that is the lack of knowledge. We think that everyone, that pain is just a normal this thing, and we don't want to accept this. So lack of knowledge, lack of training at all levels, because we have not learned this about this pain other than the pain pathway. We have not learned about modulation, which is a beautiful mechanism given by God. So addiction, we are in this vicious cycle of addiction, dependence, tolerance. There's a opiophobia among the clinicians, that there's a hitch that they don't want to prescribe opioids even in a cancer patient. So inadequate pain assessment can also lead to under treatment of pain. So we should have a complete knowledge of pain, complete knowledge of the assessment of pain, then only we can manage a patient of pain. Next slide please. So now a basic message of the cancer patients which they want to hear in pain is that no matter what happens to you, we will not desert you, and you may be dying, but you are still important to us. That is very important. Next slide please. So not all of us can do great things, but we can do small things with great love. Thank you so much for the patient hearing. Thank you.
Thank you so much, ma'am. That was pretty extensive way of going into all the intricacies of pain. I'm sure that this is, I mean, it has just opened up a world which we had once at a point of time explored in a probably in a much more superficial way, not in this much depth. But because, as you said, that this is the element, pain is the element which is like one of the biggest focus in palliative care. So thank you so much for that presentation. I would request the participants to feel free to unmute yourself and ask questions at the same time. Also feel free to use the chat box. We already have few questions coming in, ma'am. So Dr. Hina is asking, what is the difference between a visual analog scale and a numerical rating scale? Ma'am, I think you need to, you're not unmuted yourself, ma'am. We are not able to hear
Oh,
you.
I'm so sorry. So in the visual analog pain scale, you have to just show the scale to the patient. And they have to just visualize the scale and they have to just mark with their finger, or they can just say that whether the pain is 4 or 5 or wherever it coincides in between 0 to 10. So that is what is the visual analog pain scale. Numerical rating scale is just the numbers are given. You can just even ask the patient that in a scale of 0 to 10, just tell me that where is your pain when 0 is no pain and 10 means the worst pain. That is the difference.
Ma'am, Dr. Jyoti is asking, is there any objective way of measuring pain? Many a times there is like an inter-observer, sort of a difference. But then when it comes to pain, is there any objective way of measuring pain?
The best the best way of measuring pain is to listen to the patient. Active listening plays a very, very, very important part, because the person who is suffering, no one in the world can describe that pain unless and until it is described by the patient themselves. Because what they feel, what is their impact of that pain on themselves, is very well described by that patient only. So I always, in my practice, I always try to fetch the history from the patient, because no other marker can tell you about that. Because so many times the relatives are also coming and they are saying that pain is there, but they are not able to tell you about the quality of pain, what they are feeling, what is the psychological impact on them. Suppose the patient is crying, but still whatever is his or her feeling is never described by any other person. So I must say that always try to listen to your patient, in case if you want to get the catch of whatever they feel and whatever is the character of that.
Yes, ma'am. Just adding on to that, one of the things which we try following always is just to believe whatever the patient
Yes,
is trying to say, because many a times we tend to judge that with the kind of tissue injury or with the kind of disease which the patient has, it's not likely he may have this much pain. But we forget that many a times different people have different pain thresholds, and even though the damage may not seem to be much, but the pain may be on the severe side.
right, right.
Thank you, ma'am, for answering that. Ma'am, next question is, which category would breakthrough pain be counted as?
Breakthrough pain is, suppose, as I told you, that the pain can never be static. It never goes into a linear fashion like this. Sometimes what happens is that breakthrough pain can be an incidental pain, or sometimes it can be an end of dose pain. What happens is certain activities can increase that spike, that increase that pain, and that is known as the breakthrough pain. In between, in that stable static pain, also the patient can have those spikes. That is known as the breakthrough pain. Breakthrough pain can be, that is why in cancer patient we always prescribe a, other than the routine dose of morphine, we always describe the 1/4 1/6 of the dose as the breakthrough medication. That whenever they do that activity which increases that pain, it should be addressed by taking that immediate release morphine. That suppose they are getting up from bed, suppose they are going to the washroom and sitting in the washroom seat, so then they feel pain in case if they have a bony metastasis. So those triggers that we can advise the patient to take a tablet half an hour before they would like to do those activities. So that is what is the breakthrough pain.
Ma'am, can a bony or a joint pain be radiating as well?
Yes, a simple example to this is, I told you that simple example is a osteoarthritis knee. Everyone is aware of about osteoarthritis knee. Now you will be saying that osteoarthritis knee is a nociceptive pain, that there is a loss of cartilage and there is a degenerative changes and there is a pain. But what happens is there are so many multiple experiments have been done. Osteoarthritis knee, in case if it becomes chronic, years together, then it can come even to the opposite leg also. It can come to the entire body also. It can radiate also, and the character changes from nociceptive to a neuropathic pain. So that is why, means that is what is the role of a sensitization, is that a simple physiological pain can become pathological because of the under treatment and the under assessment. So it can radiate.
Thank you, ma'am. Dr. Manjari is asking, is there any standard format available for use when interviewing a patient for assessing pain?
Yes, there is so many other tools are there, and for the neuropathic pain, like there is a pain detect tool is there, and you can just make your own performers in which you can ask the patient about the aggravating factors. This PQRST, you can just type on that. You can make the pain detect tool in which some 12 points are there that can be addressed and that can be asked to assess that whether it is a neuropathic pain or not. Then so many other things are also there about the past history, present history. So you can make your own format, and it can be easily available. A certain, like pain detect tool and all are the free for all. So you can even take it from the Google also. Yeah.
Thank you, ma'am. For the participants, we do have a format, like ma'am was saying, we have made one pro forma of our own, which we use in Pallium, which as an example, we can share it with you if anybody is interested to have a look at it. Ma'am, shall we take the next questions after the case presentation?
Yes,
Is that
yes.
okay?
Yes, yes, yes. No problem. Yes.
Shri Priya, can we have the case presentation next, and then we'll go on for further discussion?
Yes, sir.
Dr. Amia, can you unmute yourself?
Dr. Mishra, you are muted. Dr. Amia Mishra, you are muted. If you could hear us, we can see you interacting, but
Oh, my slides are not visible to me. Uh, good, good evening. Good evening, everybody. Dear seniors and friends, I'm Dr. Mishra from Calcutta. I'm a participant in the palliative care medicine course, and today's topic is introduction to pain, and it is a case scenario based presentation. Next slide, please. This is regarding a 39-year-old female who had a follow-up case of giant cell tumor of right distal end of femur, which has operated twice for recurrence. She is also a case of cancer of left breast, who was operated, that is modified radical mastectomy with axillary clearance done, followed by 6 cycles of chemotherapy and 15 cycles of radiotherapy. Next slide, please. Coming to the presenting complaint, she had foul smelling discharges from a wound in the operated side of the right leg for last 3 weeks. Severe chronic pain in the right lower thigh and right knee joint for last 2 weeks. Sleep disturbance and loss of appetite for last 2 weeks, and constipation for last 1 week. Next slide, please. Coming to the history of illness, the patient noticed a bony swelling in the lateral aspect of the right lower thigh in March 2018 with progressive intermittent dull-aching pain during standing and walking. She approached a tertiary care center in Chennai, diagnosed as giant cell tumor after bone biopsy, and in dissection of the distal end femur, and reconstruction was done. But After 1.5 years, there was a recurrence of the tube and surgery done along with reconstruction and modular prosthesis in March 2021 in a private hospital in Calcutta. In December 2021, patient was diagnosed to have cancer in left breast and was operated in a trust hospital in Calcutta. Afterwards, she had florid metastasis to the lungs and liver due to delay in starting chemotherapy and radiotherapy as the family ran short of money. Finally, the family could arrange a bank loan and she was admitted 6 cycles of chemotherapy and 15 cycles of radiotherapy. She had moderate pain in the right lower thigh for last 3 years and was on irregular analgesic. Patient remains preoccupied throughout the day with hardly any communication with family members. She had decreased appetite and disturbed sleeping pattern. Next slide, please. Next slide, please. Coming to the history of pain, as Madam rightly told that pain is subjective and every individual perceives pain in a different way. So self-report is the best report. As per the patient, the pain was localized to right lower thigh and knee joint for last 3 years. Onset was slow, dull-aching type and tolerable and was intermittent in nature. Pain was aggravating on standing or walking and subsided on lying down and sitting. There was no radiation of pain. There was no diurnal variation and sleep disturbance in the beginning. Patient was not on any regular painkiller. Gradually, pain became more frequent in nature and finally continuous burning type pain, just like the applying chilies over the mucous membrane and felt even during rest. Pain increased in intensity and was 8 out of 10 in numerical rating scale. Pain did not respond to NSAIDs or tramadol. Patient suffered from apprehension, anxiety, low self-esteem, depression, loss of appetite, and sleep disturbance. Next slide, please. Coming to the examination, patient was conscious oriented. She looks anxious and depressed and answers to our questions in monosyllables. She was wondering what will happen to my children after me and why did God do this to me? On examination, patient was febrile, hemodynamically stable, and coming to the general examination, all these systems were within normal limit. Coming to the local examination of the wound, there is a discharging sinus, there was inflammation, there was warmth and tenderness, foul-smelling scanty discharge from the wound, but there was no allodynia, no hyperalgesia. More could not be done due to severe pain and no localized sensory deficit. Next slide, please. Coming to the treatment and significant investigation, coming to the routine investigations, hemoglobin was 10 gram%. Total count was a bit high, 12,800, with polymorph nuclear site is 80%. LFT was within normal limit. Serum creatinine was a bit raised, it's 1 milligram per deciliter. Serum electrolytes are within normal limit, and X-ray right knee shows osteoporotic lesions in the right knee with implant in situ. Patient was on 6 cycles of chemotherapy and 15 cycles of radiotherapy in the past for cancer breast. She is a hypertensive and she is on regular medication like Stamlo 5 milligram once daily and Telma 40 milligram once daily after dinner. And because of constipation, she was on Dufalac 30 ml after dinner. Next slide, please. Coming to the psychosocial aspects, as you know, pain can influence and pain also gets influenced by psychosocial factors. She is a 39-year-old housewife and mother of 2 girls. One is 5-year-old, another is 7-year-old. Husband is a school teacher and he runs his family with his monthly salary without any other source of income. The total bank balance got exhausted in the last 3 operations. Family has taken a loan of 8 lakhs for her chemotherapy and radiotherapy. Patient has a sister-in-law of marriageable age. Patient's in-laws are dependent on them. patient's family support structure is not that great. The family lives in a remote village of Bankura, that is in West Bengal, and nearest hospital is 10 kilometers away. Enormous stress that has affected her sleep and effect of pain on mood, social and recreational activities is also getting reflected. Next slide, please. Coming to the medications, as the patient was having inflammation of the wound, patient was given augmentin DO 625 milligram, 1 tablet twice daily after meal for 5 days, and she was given her usual routine medication, the Stamlo and Telma 40, tablet Etocyne, that is etotoxib 90 milligram, 1 tablet was given daily for 2 weeks, tablet morphine sulfate 10 milligram, 1 tablet 4 times a day was given. She was emaciated lady of weight of only 36 to 38 kg. So she was given 4 times a day morphine sulfate, tablet Pregaba NT, that is a combination of pregabalin and nortriptyline, 75 and 10 milligram, that was given once daily at 9 p.m. for 2 weeks. And for symptomatic for the morphine side effects, Jofor MD 4 milligram was given if there is any history of nausea or vomiting, and syrup Dufalac for constipation. Non-pharmaceutical methods like ice sponging to the area of pain, distraction techniques, reassurance, relaxation, and psychological support all explained to her. Next slide, please. So, what are the main concerns of patient? The main concerns are terminal cancer, chronic persistent pain, sleep disturbances, anxiety, depression, financial problem, with discharging sinus on right lower thigh, with chronic pain and inadequate family support system. Coming to the discussion points, next slide, please. So, coming to the discussion points, is it the right candidate for palliative care? Number 2, how to address her problems like chronic pain, psychosocial problems, financial status, financial issues. Does this patient need end-of-life care? And how can we provide the overall support system to the patient and her family? Over to the audience.
Thank you so much, Dr. Mishra, for that detailed presentation. Definitely a case, a person the different dimensions which you want to address for this person over here. You said that already certain medications were started. The person is on morphine and the person is on etoricoxib as well, was given for 2 weeks. How was the pain after that?
In the next review, patient was having some allergic reaction to morphine, and for which she was advised to take Allegra 90 milligram once daily, and her constipation was increasing. She was given around 50 ml of Dufalac every day night, and with that she got the relief, and overall pain score was very good. She was having the overall pain subsided more than 60%.
Identify some like non-physical dimensions of pain in this person, and what is it that you thought you could do, or what are the things which you could not do but you wish you could do for this person? Other participants, please feel free to use the chat box in the meanwhile, so that we look into it as well.
Coming to, I mean, it's a multidimensional, that is not only physical pain, because she belongs to a lower middle class family, and husband is a teacher, and they run the family with a very low salary. Here, the patient is completely now she's not talking to her family members. She wants to stay quiet in her own room. She's very much apprehensive that after her two kids, both the daughters, who will look after them? So these are many, the dimensions are psychological, social, emotional, physical, and spiritual. All the components we have to address.
Sir, in your situation, when you saw this person, apart from giving the medications, what else did you think that you should do, or somewhere which you got stuck? For example, she was telling after her time, how her children will be taken care of. How did you address that query when it came up?
The real problem is the area that is Bankuda. So I tried my best to contact to one of my friend who is there near Bardhaman, and who could help her by communicating to a NGO who is active there in Bardhaman, and Bankuda is nearer to Bardhaman. So what happened? Her family members were counseled, and they were given, I mean, emergency medications were supplied to them, because she belongs to an area which is in a very remote village, which is 10 kilometers away from the hospital. So they could provide her some transdermal patches of fentanyl. And regarding, because she only visited 2.5 months back here to our hospital, I have not much idea. Next visit is after 15 days that I can
Dr. Mishra?
All right,
I
sir.
think
All right, sir. So we're glad to know that you were able to connect the person to a local NGO
gather
who was
what
able to
exactly
do.
had happened to her.
Right, right. Sir, I think your connection has stalled a little. To be addressed with counseling support and maybe with antidepressants as well. So a situation where so many dimensions needs to be addressed, and always a doctor alone may not be able to handle it. many a times we may have to go for a multidisciplinary approach. In this situation, you said that an NGO has come into the picture as well. As we come towards the last few minutes of our session, ma'am, your take on the case discussion or the case which was presented.
What I learned in all this entire decade of 10 years of my pain and palliative care is that the first question we should always ask to ourselves, that what best I can do for this patient. Connected with the NGO. Now, in each and every localities, some or the other social workers are usually there. So we should always try to connect our patients to the social workers, and always whenever the patient is coming to the follow-up, we should make them into confidence and always explain them that we are always there. We are always there with you. We will not never desert you. Distance is no bar, money is no bar. Always just try to explain that we are always there to help you out, because this is the only time each and every department of the medical fraternity they leave the patient, but it is only the palliative care department who always accept these neglected patients and provide them the best care within all the any person. Means the PHC should also be there, I think, in that center, because PHC, small PHCs are always there in one center or the other. We can connect the patient to that PHC in case if any sister or any nurse staff is there to take care of that wound, because that wound is having the discharging sinus, and this is a social stigma for that patient, that a foul smelling discharging sinus, no one would like to come near her, be it the family members, be it the social gatherings or whatever. So that isolation feeling should also be addressed, that there should not be a proper wound care should be provided nearest to the door, and such patients should not be isolated, and to provide palliative care is at home, and there is no other place. I know that there is a limitation. Hospices are not there, home care services are not there, but still I feel that that wound needs to be taken care of. That psychological aspect needs to be taken care of. Patient should be taken care into confidence that we are always there with you. Try to connect with that patient, even telephonically, through the virtual media. Keep on talking to that patient, keep on talking to the entire family, that what are their views, and attach them with the social worker, so that the brunt of the financial aspect of their kids education needs to be taken care, because she should be there in peace, and in case if we have the right to live with a dignified life, so we should always provide a dignified death also to the patient with system needs to be developed, and we should always talk to the patient that what they want, what is the reason to live, what are their spiritual aspects, what she wants, so that also needs to be addressed. That is
Very wonderfully put, ma'am. This is the best message as we move forward in our sessions with respect to palliative care. The many dimensions which is there, which needs to be addressed, we most of the times, or 99% of the times, we cannot play a one-man show. It is always an involvement of multiple people, and many a times we have to liaise with the community, because at the end of the day, the people who are nearest to the person, many a times the person may not be able to even reach up to the doors of a hospital or a palliative care center. And this is where decentralized care, where the doorstep doctor or the doorstep community